Hey, and welcome everyone to EuroNurse. We meet every Saturday at 9 a.m. Central Daylight Time. If you're watching us on YouTube, please check out our website at euronurse.com to find out how you can participate in this program. Our first half of our program will be just general questions. So go ahead and start submitting those. To submit questions, remember, go to the Q&A box on the bottom and put your questions in there. Our second half, we're going to take a deeper dive. Today's subject's going to be, we're going to be talking about erectile dysfunction. A lot of good questions that come in on that one, I'm sure. So let's get ready to roll. What I'm going to do next here is I'm going to go and switch over to my questions that I did receive throughout the week. So here's some questions that I've gotten. We'll talk about those with the group here. So Abigail Risardo sent in this question. What have you guys done in the past for Urologic Nurses and Associates Week? So I'm going to open that up to the group. Any thoughts here?
Yeah, so actually at one of the conferences, I think it was a national conference, they actually were through the SUNA website, they were giving out balloons and buttons. So I gave everybody a button and a balloon. So you can go on the SUNA website, they have stuff that you can actually purchase to give to staff.
Yeah, that's a good idea. There's stuff on the SUNA website. And attendees, if you've got some thoughts on what you think you do for Nurses Week or Urologic Nurses Week, go ahead and submit those on the questions. I'll read those out loud. John, you do anything for your office?
Well, I think it's important to recognize your staff throughout the year, and certainly medical professionals holiday, like the administrators holidays and MA special days. We try to do something a little extra for those individuals, but I think it's important to recognize and make everyone appreciated every single day.
So every day is Urology Healthcare Workers Day.
You know what? For the qualified health professional, I call APPs and physicians QHPs, qualified health professionals. That's Medicare speak.
Yep.
So for all QHPs who serve patients, I think at the end of the day, the least you can do is say, hey, goodbye or thank you. I am still working on that because I often go from clinic to telemedicine. And by the time I get done, everyone's walking next to me, but at least I'll say goodbye, like wave goodbye to them. If it's a particularly busy day, you certainly want to say, hey, you know what a great day. Thank you so much for a great day. So recognize people. It doesn't always have to be monetary or gifts. Sometimes words of appreciation mean a lot. And I think we all should do that every single day.
So before I went into partial retirement, I was the administrator for our practice. And I would always tell them, you're my favorite.
Oh.
And so recently, one of the MAs was a new MA had started, and she goes, I just want you to know I was Vic's favorite. And I go, and if you were working, you would be my favorite too. She goes, yeah, everybody was his favorite. But like you said, it's just that appreciation. Lori, you had a comment?
Yeah, so I mean, even like this past week, we had a rough time. We were short-staffed and whatever. We had one of our receptionists, she was by herself. We had 70 patients that day. So she's checking in, checking out, answering the phone. I mean, one person. Yeah. And so I just sent a simple text to her that night saying, you know what, you don't go unnoticed. Really appreciate what you do. You're a rock star. And that made her feel so much better.
Yeah, I agree. I think that's huge to recognize people. I'm going to go into our next question here. So Abigail Ricciardo asked, I'm being asked to revamp the way we keep tabs of our BCG count at work. I thought a simple tally to begin count and end count would suffice, but that's not so because it's misleading in terms of how it does not show the count that is free to allocate. So anybody got some ideas on how you keep tabs of your count? Lori, any?
I guess it depends on, so our allocation is small. It's 2 vials a week. And if we get it, we get it. We don't, we don't. Luckily, it's been consistent for us. I guess the question is how many, I hope Abigail's on here, like how many BCGs are you doing? And because we know our count in our fridge. We get it, I email the pharmacy weekly asking how much they have. left, because I want to make sure I have enough for, of course, all of our patients. So I guess I want to clarify, I want her to clarify the question for me.
Yeah. I know in our case, we'll take and label a group of 6 and put it, because it's kept refrigerated in the fridge. We'll label it with that patient's name so that we know we're going to be able to get through that patient's, because you say with the shortage, sometimes, you're robbing from Peter to pay Paul. So we didn't want to start somebody not be able to complete their treatment. So we would label 6 of them, put them aside for that patient. And we do that as patients were registered to be started on BCG. I don't know if that's really helps what she was asking though.
Yeah.
That's a tough question to answer, because you may have patients. So I think she's maybe asking, well, here are the existing lot of patients who are getting BCG. How do you know how much you have left over as the free amount for the new BCG patients? Maybe that's the question. That's kind of hard to answer, because with the shortage, with the allocation, sometimes the regular BCG, the known BCG patients, they're getting half dose or a third dose. So you kind of then have to break up that one particular dose into multiple doses. And then how do you communicate that to everyone else?
Yep. Yeah, you're right. It's very difficult to answer in today's situation. Back years ago when it wasn't a problem, I think keeping the dose so you make sure the patient had all the doses they need was the best you could do.
I think
all right, I'm going to switch. Go ahead, Lori.
One of the things that I found out is that, we have a certain ordering system through Northwestern. And even though the allocation is 2 per week, you can contact Bessie themselves, and they may be able to get you more, because some people may not need their allocation, whatever. So I highly advise people to reach out to Bessie itself, and you may be able to get more BCG.
Yeah, good comment. Okay, I'm going to take the next question. And by the way, this is a great idea, folks. If you've got questions you want to submit throughout the week, just go to the website. There is a submit questions, and gives us a chance to kind of look at them ahead of time. Monica Friedman from California sent this in. Your example regarding leukocyte esterase in urine, what could this indicate? And is there a threshold used to treat for UTI? And I think this one was to you, Lori.
Yeah. So I can totally answer that question. So leukocytes in the urine, oh my gosh, I think probably 90% of the patients that we dip probably have trace to large leukes. So it can mean many things. If they have a stent, if they have stones, if they have, obviously infection, it could be contamination. A lot of times, especially with women, they're always going to have some kind of loops in their urine, and most times it's contamination. So it really depends on the patient's symptoms to really evaluate whether those loops are indicative or not. Very important to send it out for that culture to confirm. We don't usually send, or we always send a culture if we have any kind of loops in there, depending, on what but if somebody definitely presents with any kind of urinary tract symptoms, we do send it out if they have any form of leuks.
Yeah. John, you wouldn't treat just based on leukocytes alone, would you?
No, leukocyte is such a non-specific measure of one of the indicators that we look at in urine. So like Lori said, if the patient's symptomatic, then you would possibly consider starting with empiric antibiotic and then send it for a culture, adjust the antibiotic in a couple of days as necessary, depending on the culture sensitivity. But having a certain number of leukocyte esterase doesn't mean that someone has an infection. It could be, like Lori said, could be a contaminant, could be age, could be menstrual cycle. So a lot of different things can cause that leukocyte esterase. Looking at the patient clinically, urine culture, maybe some of us may even look at it under the microscope. If you see bacteria, lots of bacteria, then there's bacteria in the urine, patient symptomatic, you may want to start antibiotic treatment and send it for a culture. But leukocyte esterase alone, hard to say what is exactly going on. And like Lori said, a lot of urine will show leukocyte esterase. It freaks out patients, especially when they do the home testing kits. Mm-hmm. Good and bad.
Yes.
Yeah.
Also,
it could be nothing. It could be tuberculosis, even though I've never seen a case of it. So it's hard to tell.
I think it was a good question to ask because it did need some clearing up. She also asked,
Definitely.
in regards to pyuria in the urine, pus, white blood cells, is this the same as leukocytes in the urine? I think that's easy enough. I'll just answer that one. Absolutely, it's identical, same thing. And then her third question, for those with a suprapubic tube who have recurrent UTIs, are there any other specific measures to help avoid UTIs other than the bladder soak with tobramycin, gentamicin? Lori, any thoughts on that?
Oh, so yeah, that's a difficult one. I guess the question is whether the patient is actually symptomatic every time. I mean, if I had a patient yesterday who had a suprapubic tube and it was a new one, and she's like, oh, I think I have an infection because, I have a cloudy, foul smelling urine. I said, well, do you have any other symptoms? Do you have any pain? No, we're not treating it. So I guess the question is this person truly getting reinfected? What are their symptoms? As far as, I mean, you could do the methenamine. I mean, we've had people on the methenamine, which works very well as opposed to the gentamicin installations. But drinking water, obviously more fluids is going to be best. And it's really important to check, really, are those symptoms related to urinary tract infection?
Yeah, I think that's a good point because anybody with a catheter we know is going to get colonized, and it's
Right.
whether it's symptomatic or not as to whether you would treat. And I think you kind of covered most of the things I would have thought of. I don't know, John, did you have any other thoughts on what you would do? Or
Well, I think some of it may be was things that the patient may be able to do, which is to drink lots of fluid so that you can just flush the bladder. Unfortunately, sometimes with the indwelling catheter, it's going to most likely going to be colonized with bacteria. And like Lori said, if the patient is symptomatic, then you might want to treat it. And the presenting symptom may differ. Could be mental status changes. It could be foul smelling urine with something else. But foul smelling urine alone, I was counseling a patient yesterday. Foul smelling urine alone does not mean you have a bladder infection. This is a lady who's on clean intermittent catheterization with a neurogenic bladder. So just because the urine looks cloudy or foul smelling, it doesn't mean that you have an active infection. Unless there's something else going on, you may want to consider not getting on antibiotics right away, simply drinking more water. And for her, she needed to self-cath more when she noticed this cloudy urine to drain the bladder.
and Monica Friedman she's on as one of our attendees here, did follow up. Yes, this patient has symptoms, always symptomatic with the suprapubic tube. So that's
What kind of symptoms? Hopefully she can
maybe.
Just curious.
Yeah, because you wonder, suprapubic tube can cause bladder spasms. One of the things that I kind of noticed is if anybody looked at a catheter, the tip of a catheter from the balloon, the distance, it changes whether it's a 5 cc balloon or a 30 cc balloon. They have longer, John's got one up coming up. I'll have you talk so that it brings, you have to say a word or two so it brings your picture up on the main frame though.
Oh, okay. So this is the tip of a catheter, and here's the tip of the catheter, and the balloon is here. So that, Vic, I think you're talking about this difference between
Right,
the tip
exactly.
and then this.
So what I've noticed with suprapubic tubes, you want a short tip because the longer the tip is beyond the balloon, the more irritating it can be to the bladder because that bladder's always collapsed. And just, I think the way it sits in the bladder, it seems to be more irritating. And I've just used a different size catheter. Usually the smaller balloons have the shorter tip.
With recurrent infections, I guess the question is also how often is the suprapubic tube being changed, and has that patient been scoped? Like maybe there's something going on that's causing these infections that maybe they need a cystoscope.
Yeah, good point. Yeah. Bladder stones.
Right.
We do have a
Struvite
question here.
stones.
How long can Hyprix to be ordered for UTI anaphylaxis? Anybody using Hyprix? Hyprix. Do you use that, Lori?
I
Well,
think it's the same as methenamine.
I think so. Yeah.
So I don't know if there's actually I think people are on it long-term, as far as I know. I mean, I've seen people on it long-term, so I don't know. Dr. Lynn, do you have any?
Yeah, I don't usually use this long term, so I don't really know what's the indication, or not indication, but how long
Yeah.
you can prescribe it.
Yeah.
I have another question here from Maria Pinnock, who said recommended weekly bladder irrigation and check for bladder. Claire Gabara is asking, what formula do you use for gentamicin installation and how often do you do it? Do you have a set formula for that?
Yeah. I don't think
Right
there's
off
a
the top of
set-
your head, right?
I don't think there's a set formula, but I think, I mean, I haven't done it in a while, but I think we use just 80 milligrams of gentamicin with, I don't remember, it was like 50 cc's of normal saline is what we used.
Uh-huh.
And we just instilled it and let it sit there for 15, 20 minutes and then drained it out. I don't think there's a set formula on it. So I think it's just doctor dependent.
I think it's kind of voodoo, but
Yeah.
sometimes it works.
Yeah.
I've got one somewhere. I'll try to see if I can put that up on the website because I just don't recall where right off the top of my head what it is, but there's a formula I have.
Highly doubt you're going to find level A evidence on that one.
Oh, absolutely not. It's going to be strictly off the cuff, but it's what we've done and it's worth to look at. But you're right. There was no evidence. Patient Monica Friedman says patient always knows when he's getting an infection, high fever quickly. Yes, he has been scoped, suprapubic tube change monthly. That's just a difficult patient to manage, I would say.
Don't forget the upper tracts. Get an ultrasound of the kidneys.
Good point. We have a question that came in here from Jan Amory Arbrenica. Welcome. I think it's a new name. I don't think I've seen this one before. When placing a patient on antibiotic prophylaxis, i.e. macrobid 100 milligrams daily, what are your recommendations in duration of treatment before discontinuing the medication? We usually recommend 6 to 12 months. What do you do?
Yeah, that's exactly what we do. Is usually we don't let them go past 12 months. 1 year is, as long as they're doing well, then 1 year is fine. And then we take them off it for a trial.
I think that makes a lot of sense because whatever the factor is that was causing recurrent infections may not exist anymore. And I think that I think maybe John had mentioned last time not to forget about the use of hormones, estrogen for females with recurrent infections. That a lot of times it's just that pH balance that can be restored with the use of estrogens.
Definitely. Hey, before we forget, Vic, if you don't mind, I'll welcome April, Charlene, Claire, Francis, Jackie, Jan, Maria, Marty, Michelle, Monica, Neil, Paula, Rochelle, Rebecca, Robert, Susie. Thank you so much for joining us.
Yeah, we have a great group of attendees coming in. So if there's not any other questions, I'm more than willing to get into my lecture, open up a little more time.
Can I talk about something real quick?
Go right ahead, because I got a few buttons I got to push on my side.
Yeah, that's what I figured. So I'm showing you this catheter. This is actually let's see, this is from Coloplast. It's their X-Flow catheter. And last week we were talking about catheters, and I was mentioning how this one, so if you look at it straight on, this is an elbow, a coude catheter. It has this bend. For this particular catheter, I don't know if you can see this. There's a white line on the back end of this catheter. So here's the bend, here's the back end. So when you're putting in the catheter, you know the orientation of this coude. It is important to know which orientation that tip is pointing. And on this side, you'll notice that the bend correlates with this yellow thing here, the infill, the balloon port. So when you're putting it in, as long as you know the orientation of the tip of the catheter, you'll stay out of trouble and you will not stick it into the 6 o'clock position of the bulbar urethra. So goes in this way. How did I do? Did I give you enough time?
Perfect.
Gosh.
An excellent stall.
Love it.
Love the picture.
So in case you haven't guessed, we're going to start talking about erectile dysfunction. And I did decide, because I like this short system, this program, having a shorter talk instead of these long 1 hour talks, breaking it into parts. And I'm thinking that it's definitely a 2-parter, could be a 3-parter. We'll see what people think. I've got some ideas. But anyway, part 1, we're going to mostly look at the medications. So I like this definition. It's old, came back in '83 by the NIH, but I think it really covers almost every perspective of erectile dysfunction: a persistent inability to achieve or maintain an erection sufficient for satisfactory sexual intercourse. Now, some of the statistics looking at for this year, there were some estimates that now the worldwide prevalence of erectile dysfunction is around 152 million men. And they're predicting that that number will probably double by the year 2025. So there's definitely a thing that we really need to look at and treat on our as ages are going up. We also know that erections are going down. So this is kind of interesting. And whenever I talk to patients about the risk of erectile dysfunction, I always say that there's a decade effect. And basically what I mean is that you can kind of almost match your age to your percentage risk. So a 50-year-old man, 50% risk of finding that they're going to have some problems with the erections. And this is really kind of held out. I think it's somewhat reassuring too, because patients realize, hey, it's just not, a problem that nobody has. It's just me. But if you haven't heard that one, it was University of Wisconsin Health put that out in 2019. I've really followed it. It also answers a lot of questions that I have why men tell me they never want to live to be 100. So now, heart and the penis share a lot of risk factors. So erectile dysfunction and heart disease kind of go hand in hand. And we know that being overweight, high blood pressure, smoking, diabetes, sedentary lifestyles, and high cholesterol can all lead to increased risk of heart disease and erectile dysfunction. And actually, erectile dysfunction may be one of the symptoms that's an early indication that you need to look at vascular disease. It makes sense if you look at the penis vasculature versus the cardiac vasculature. These are much smaller. So if something's going to start obstructing smaller vessels, it's going to start working on affecting your erection before it may affect your heart. So definitely something, if somebody comes in with erectile dysfunction, you also want to kind of focus on a total look evaluation. Other risk factors are listed here. And, some of the times there are things that are preventable, like smoking, drug abuse, and Peyronie's disease is listed. I think it's considered one of the causes of, or one of the symptoms of erectile dysfunction. That's one of the areas I was thinking it'd be great to find somebody who does a lot of Peyronie's treatments to do a talk as like a third part of this. So we'll see if anybody out there has someone they want to recommend. That'd be great. But that's, I think, a talk on its own. And these are the drugs that are often associated with erectile dysfunction. Some of these, you can switch certain high blood pressure pills and have, if they find it's causing their erectile dysfunction, that can change it and make it better. Some of them obviously can't be avoided. And then there's some that can be, such as alcohol use, marijuana use. And I think that, if you let patients understand that some of these things that they're doing can have an effect on their treatment options by just decreasing their lifestyle changes, increasing their lifestyle changes. In 2007, the AUA put out this treatment algorithm, which looked at, how do you treat ED, and said that very same thing: identify treatable and curable causes of ED. So if you can find somebody that has something that can be changed, a medication change or things like that, go ahead and do that. Encourage lifestyle changes. Sometimes losing weight, things like that can help. Stopping smoking, that could help. Provide education and counseling to the patients. And when that fails, that's when we go into actual treatment options. The treatments that are currently available are surgically. They can implant a penile prosthesis. These are either inflatable devices like I have shown here in this picture, or they can be a rigid device that can just be bent out of the way. There's external vacuum devices that can fill the penile cavernosum with blood by an external vacuum. These are actually over-the-counter devices. And there's injections where you can cause a pharmacologic erection, things that you inject in the penis that'll cause it to become erect. The same drug can be used in a somewhat topical form. It's intraurethral. You place a little pellet in the urethra that can cause erections. And all 4 of these are going to be part 2 of my next talk. So that's a little, what they call a teaser in the business, right? So stay tuned. But we're going to talk today about the actual pharmacologic treatments, the pills that have been available. And they're by far the PD5 inhibitors have been the #1 drug in treatment. And that all started with the little blue pill called Viagra. In 1998, it was approved for the treatment of erectile dysfunction, sildenafil. It was originally used as treating blood pressure issues, and suddenly these patients were complaining that they were getting erections all the time. And somebody said, there's a good idea. Let's see what that's all about. The next drug to come out was vardenafil in 2003. It was approved, and it comes in 2 different forms, the Levitra and the Staxin. Levitra being another pill form, and Staxin actually having a unique property in that it's a dissolvable pill that you could put under your tongue or dissolve on your tongue. And the thought is it may get into the bloodstream more quickly that way. In 2003, tadalafil or Cialis was introduced, also with a unique property in that it has a very long half-life, which allowed it to be a pill that you could take once a day and kind of be like the ever ready bunny, always ready to go. And then in 2012 is the last one that's come out, and that's called Avanafil, and that's the generic name. It's Stendra's their regular name.
Vic, I'm going to correct you in that the patients who were in the study for sildenafil or Viagra, they were not complaining about their erections.
Good point. They were bragging about the erections.
They didn't want to give the medication back. It was actually a medication being studied for pulmonary hypertension.
Yes, absolutely. All these drugs do have 2 things in common. When they came out, very expensive drugs, $14 to $20 a pill. And remember, this was back when they were first introduced. So, imagine what it would have been in today's day and age. And the other thing is, except for Stendra and Staxin, they're all generic now, which is a great thing for patients because somebody had told me you can go on that GoodRx site and you can get, I think it's the daily Cialis, the tadalafil, the generic, for like $1 a pill. So it's very inexpensive to use nowadays. So how do these work? Well, penile erection is mediated by nitric oxide and cyclic GMP. Before everybody falls asleep, I've got nice pictures to make it easier. So this is how I like to envision things in my head. I need to have some kind of visual cue. So when a stimulus, excites a person, the nerve cell starts to secrete or push out the nitric oxide. Nitrous oxide then activates the soluble guanyl silase, which then causes the rise in cyclic GMP, and that causes relaxation of the blood vessels. Blood flows into the penis. And if you look at the picture that I have here, you can kind of see the arteries as they start to expand can push against the veins. So you have an increased flow, a decreased outflow, and there's an erection for you. Now, why does the PDE5s work? So the activity of cyclic GMP is modulated by this enzyme called phosphodiesterase. And in particular, there's a lot of 5 found in the penis. So again, I like making simple things for me. I hope it helps you guys. But the way I look at it is erection's kind of a balancing act. You have your nitrous oxide, cyclic GMP on one side and the PDE5 on the other. If you change the balance, all of a sudden you've got an increase in nitric oxide. It drives that system and you have an erection. Of course, if there's a lot of PDE5 sitting around, then that erection may not occur. And that's why we then prescribe the pills for the patient to take their inhibitors to get rid of that extra PDE5. And that's exactly what it does, thus the desired effect. So I hope those visuals were good for you. Only way I can keep this stuff straight in my head. Now, some precautions. PDE5 inhibitors should never be used with organic nitrate medications. It can really just about knock your blood pressure to nothing. And nitrite drugs include the following list. So they say anybody who carries nitroglycerin around in their pocket should not be on a PDE5 inhibitor. And these other medications that are taken on a regular basis should not. And then, of course, the illegal drugs like the alkyl nitrates, they're poppers. Again, they should be warned. Now, I think patients need to know all that too. It's important not to assume that everybody's not using these illicit drugs. Cialis, Levitra, and Staxin and Stendra should never be taken if you have severe liver impairment. Levitra, Staxin, and Stendra are contraindicated if you're on kidney dialysis. But Viagra can be used in both this population, but at the lower dose, the 25 milligram dosage. Now, interestingly, a recent, I was doing some search in the literature, and actually PDE5 inhibitors are being looked at for helping to prevent certain kidney disease, such as diabetic nephropathy, ischemia, and acute chronic kidney injuries. So even though you're not using it in dialysis, there may be some protective mechanism by PDE5 inhibitors. So these medications are going to be more than just in the bedroom now. And there's been a broad range of preclinical and clinical studies looking at the use of the PDE5 inhibitors as anti-cancer agents, low side effects, and they've got some promise. So I think we're going to see these drugs popping up more and more. Popping up, pun intended. Dosing guidelines I put here for you. As you can kind of see, most of the medications have about a 4 to 5 hour duration. Stendra's unique difference was it has a longer duration, 6 to 12 hours. That doesn't mean a 6 to 12 hour erection. That just means that you can obtain an erection during that time. None of these drugs work without sexual stimulation. So they just, again, as I did with my diagram, they take the PDE5 out, but you still need a nitric oxide increase to cause an erection. Cialis, again, as we mentioned, with the long half-life, 24 to 36 hours. So you could take a low dose of the medicine and it'll keep building up over time to reach a steady state of, say, 10 milligrams. Most of them are taken about an hour before sex. The Stendra supposedly works a little quicker, so 30 minutes before sex. And again, Cialis can be taken once a day. Cialis is the only one that is used to treat BPH, I think because of its once a day ability. So 5 milligrams once a day can treat both erectile dysfunction and BPH. Now, I know we had some talk about this, so I looked up an article on modifications. Somebody had said, basically in general, PDE5 inhibitors are contraindicated with alpha blockers. So somebody that may be suffering from BPH could be a good candidate for Cialis for that reason. But I did find some adjustments and modifications that are suggested that I think could help out here. So Viagra, you can start with the low dose if taking alpha blockers and increase it under the direction of your practitioner. Cialis should be limited to daily intake of 10 milligrams for mild liver impairment and 5 milligrams if on kidney dialysis. The daily should not be increased beyond 5 milligrams per day for BPH. Levitra and Staxin, you can decrease to 5 milligrams for males over the age of 65 and increase only under direction of your healthcare provider. Decrease to 5 milligrams daily, never to exceed 10 milligrams daily if you have mild liver disease. And finally, Stendra, decrease to 50 milligrams of taking alpha blocker and increase under the direction of your practitioner. You're watching for blood pressure issues. Excuse me. And I'll be glad to put these modifications on the website so you can have that to look at. CP450 is an enzyme the body uses to metabolize drugs. And these are a list of those in CP450 inhibitors. You should be very careful and not prescribe PDE5 with those because it can increase their strength by as much as 11-fold. And that's a list of those drugs. Again, I can put that on the websites for anybody who's interested. So side effects, common side effects include headache, dizziness, flushing, upset stomach, nasal congestion, muscle aches, nausea, back pain, and bluish visual disturbances. It says mainly with Viagra. I don't think I've ever had a patient complain with any of the other drugs. And I've only seen a few patients that had the blue vision with the Viagra, but it has been, there have been several patients I've had note that. Most common one I hear is the nasal congestion and the headache. So, and I've told patients they can try taking Tylenol with it and see if that'll help the headache. And some have reported that that was all they had to do and it was fine. I've never seen dizziness, but it makes sense that with the orthostatic hypotension that could occur, that might happen. Flushing more common than upset stomach. I've never had a patient complain of. I haven't had anybody complain about nausea either. Severe side effects. We always warn patients that any erection lasting more than 4 to 6 hours should be considered a medical emergency. They should report that to their physician, probably report to the emergency room. This other one's more important. Sudden vision loss can be related to something called eye stroke. So again, if somebody reports a sudden vision loss, that's a medical emergency. They need to seek emergency care. And sudden hearing loss is another possible side effect. Again, they should seek medical attention for that. And at this point, folks, it's up to you. So you're ready. Go ahead and submit your questions, and we'll be glad to start discussing everything you ever wanted to know about erectile dysfunction. And I'm just going to swing over.
There's a question by Claire who asked, alpha blockers, does this include Flomax and other meds for BPH?
Absolutely. All those are alpha blockers. So that would be included. So attendees, now's your chance. Any question you want to ask me, or the panelists, I should say. We're all working in the same area.
So can you comment on Trimix? Because we use that a lot in our office.
That's for the next
part two.
It's part two. Okay, never mind. I'm getting ahead of myself.
Yeah, that's really the area that I think, obviously as a nurse, the physicians are the ones that are doing the prescribing for the oral drugs. Nurses are doing the education side of it. The vacuum devices, the injections, that's been my specialty since they came around. So I've been in this business long enough to remember when, papaverine was around. So I thought I'm going to break this out to a second session because it's going to be long enough to kind of talk through give you my historical perspective because I've got history.
I think it's great to get that historical perspective.
It's something that aging does help with when you've been around when some of these things were first coming out. As you said, like the original studies for Viagra, knowing the history is kind of interesting. Most of us just know that's the blue pill for erections.
Yeah, Bob Dole did Congressman Bob Dole did a great job with the advertising. He endorsed it, and then the word got out. It brought ED out of the closet, if you will, and then everybody started talking about it. I'm hoping that for women, the use of estrogen will be brought out of the closet, and that more postmenopausal women will be on estrogen, so that it would benefit them. As far as cost I'm not seeing any questions. As far as cost for these medications, I'm just looking it up on goodrx.com. I actually did a presentation about this, I think on my personal timeline on Facebook. 30 tablets of 50 milligram sildenafil, generic Viagra, $5.28. It's
amazing, right?
Yeah. I have seen it where it was $40 per pill in the past. And since it's gone generic, it's great.
Oh, yeah.
It's so much more affordable for a lot of men.
Yep, definitely. So I'm lucky. This year I'll be turning 65, so I get to start Medicare. And I was talking with the insurance guy and about what drugs to take, and he was saying, well, he says, just in case you wanted to know, he says the erectile drugs are not covered by Medicare. And I go, okay. He goes, yeah, but he says go on GoodRx. He says you'll get it for only a few dollars. So he had it covered.
So there's goodrx.com and Cost Plus drug companies, that the one that was started by Mark Cuban. That's another source of inexpensive drugs. So
Claire Gambara sent this question in. Any thoughts on penile ultrasound treatment? I wonder if she's considered, if that's the shockwave that she was asking about.
She's probably talking about the low intensity shockwave therapy for erectile dysfunction. There's even a device that's marketed directly to consumers. You can buy this $800 device and it's sold directly to consumers so that they could provide their own low intensity shockwave therapy. And I think the most recent AUA position is that these types of therapy should be limited to experimental and research arenas instead of the mainstream. Yeah, there are some practices that use it to generate revenue. I see a lot of guys who continue to suffer ED after they spent their $3,000 on these treatments. But that could be selection bias, right? They're coming to see me because the treatment didn't work.
Could be.
Or the guys who tried it, it didn't work. They're too embarrassed to seek additional treatment because they lost all that money.
And maybe their faith in the medical system too.
Yeah.
So, Lori, have you had any experience in your practice with
Not at all. Actually, this is the first time I'm hearing it.
Yeah, we have one. We're part of a larger group. None of the guys that I work personally with used it, but one guy has. I mean, I don't know of any success stories, but it was out there. He offered it, and I don't know if he still does.
It's a cash cow. That's why a lot of these places do it. $500 per treatment, 6 treatments recommended. That's about $3,000.
Wait, you mean medicine does things for profit?
Well, I hate to say this, but no margin, no mission. No margin, no mission.
Absolutely. And patients seek this out too. Some patients say, I want something else. So it's driven by patients too. We shouldn't, pick on the physicians either on it. We do have a question here from Jan Amory Arbanica. Would you recommend cardiology clearance before starting PDE5 if there's a history of CABG, CHF, and cardiac stents, etc.? So the cardiologists that we've worked with have always kind of stated if a patient can walk a flight of stairs, they can probably use the PDE5 inhibitors. Again,
we have doctors that actually, some of them are more lenient than others. Some, patients walk in with ED and they're like, oh, here's your Viagra. And then we've got some doctors that are like, no, you need a full medical workup. Get that physical and get all their blood work done because it may be some other underlying cause. It's really important to find out if there's an underlying cause.
Interestingly, we've seen a lot of patients that were referred by family practice physicians who weren't comfortable with prescribing it just for those reasons. So they were sending it to us.
I reserved the cardiac evaluation. Exactly. If I ask the patient, do you have any trouble if they're just walking in and they don't have any known cardiac history, or if they have a cardiac history, are you on nitroglycerin? Do you have any trouble climbing up a flight of stairs? Those are common questions that I ask among my patients complaining about ED. Also, the younger patient complaining about ED, those are the ones that I say you have to have an evaluation by your primary care because it could be a harbinger of cardiovascular disease. So yes, I will give them the treatment, but then I document that in my chart that I ask them to seek primary care evaluation for underlying cardiovascular disease.
So Paula Wagner sent this question in. Can you go above the FDA dose? Good question. I can't say that in our practice we've ever recommended it. to push higher doses, we recommend going on to something different like the injections. John, any thoughts on pushing the dose in your office? Or?
No, I do not commonly recommend. Even though the patients have the medications, they're going to do whatever they want. Some of the patients have gone above the FDA recommended dose, but I personally do not ever prescribe above the FDA dose for fear of things like priapism.
Right.
And speaking of priapism, you want to make sure that the patient's not abusing crystal meth, cocaine, and things like that, because that's along with PDE5 inhibitors. So just something to throw out there.
Yeah. As I mentioned, don't just make the assumption that patients aren't using illicit drugs.
Yes.
Because they are. Marie Pinnock said, any thoughts on the new treatment radiofrequency, not FDA approved and very expensive? I don't know about radiofrequency. Anybody in the panel? I think you stunned the panel here. Rachel Smith asked. Go ahead, John. You had a question.
Oh, not familiar with that one. Sorry.
Yeah. One that I'd be interested in hearing more about it, but nothing I've heard of. So Rachel Smith said, I think it is important to tell patients that medication still requires stimulation for erection to occur. What do you think about that, Lori?
Yeah, no, absolutely. You have to have something in order to make the drug work. So, and I was going to ask a question because in our clinic, we're seeing a lot more younger and younger people coming in. And in my observation, it seems like it's more psychological than it is actual. I mean, we do the workup, we make sure that they're okay, but what do other people experience in that?
I find that there's sometimes some unreal expectations of patients. You ask them and their problem, they're complaining not that they can't get an erection, but they can't get an erection can't perform sexually 5, 6, 7, 8, 9, 10. Yeah, exactly. And you're like, I don't know if that's really what I would define as a problem. I think that's, maybe there's something else going on here.
It seems like, I think with all these drugs coming out and all the hype about it, that the younger, I mean, we're getting 20-some-year-olds with it. And I don't know exactly. And our docs actually still give them something to try. And to me, it's like, really? I don't know.
Let me go back a little bit on the effectiveness of these medications. It's important to counsel the patients when they come in. Often the patients seeing me, they've tried the medication before as prescribed by their PCP or were given samples. They say, oh, it didn't work. It's important to counsel them on the appropriate use. How do you use it appropriately? You have to take it about a half an hour to an hour before you plan to engage in sexual activity. You have to be in the mood. You can't be reading the Wall Street Journal and expect something to happen with the penis. You want to avoid fatty foods before taking these medications. So when you use it appropriately, and if that really didn't work using that particular dose, then you may want to consider escalating the dose before you change to a different medication or different type of treatment. So that's important to know. And number two, for a lot of these young guys, it's like you said, Vic, unrealistic expectations, or this is most likely a psychogenic type of erectile dysfunction. Often it's performance anxiety. For whatever reason, they lost that erection. And then on subsequent encounters, they're worried about, am I going to be able to achieve and maintain an erection? If you point that out to the patient, he'll often say, oh yeah, I think that may be what's going on. In that situation, I will say, I'm going to give you this medication as a Band-Aid to help kickstart your erections, to give you the confidence back so you can get back in the saddle, and then most likely you won't need to continue to take the medication. But if they come back for refills, I will tell them, you may want to consider cardiac evaluation, because this is indicating, the canary in the coal mine, that there's something going on with your circulatory system, with your cardiovascular system, and you need to have further workup and potential treatment.
Yeah, that's a good point, John. And one of the things I think you forgot to mention was alcohol.
Oh yeah.
You go out for a nice night, dinner and a few drinks, and then take your Viagra and it doesn't work because alcohol's going to have an effect on the erections.
I learned that in high school during English AP. According to Shakespeare, alcohol induces and brings about the desire, but takes away from the performance.
There you go. Even Shakespeare knew. And interesting, you had mentioned about the performance anxiety. Before these drugs were available, we had a psychologist at our hospital that was treating performance anxiety. Well, he started directly referring patients to me. He said, because I had a higher success rate with the injection therapy than he ever got with his psychotherapy. So it was almost crazy. We used to send him the patients. Now he's sending, and it wouldn't even write to the doc. He said, CVIC. He can take care of you. So it was interesting, but you're right. It does. It just getting him back in the saddle again. All right, good. Claire Gabara did come back and say, yes, she was talking about shockwave. So good. Thanks. That's what we were thinking. Neil Smith writes, are any penile implants being saved for part 2? I was wondering if anyone is still placing malleable implants. And are there any special considerations Uro RNs need to know in the care of these patients versus inflatables? Oh boy, Neil, you got to stand by for part 2 because I'm going to talk all about those things. And there are a lot of things that you do need to know differently. It's a whole game changer once you do surgery. It takes away a lot of other options too, but we'll leave that as a tease for you. Let's see. Claire said, I'm asking because we have a clinic who has a commercial on TV about that. Interesting. So that, as John said, it's a moneymaker. Not surprised.
And I'm sure it serves some patients.
Mm-hmm. Susie Swain writes, what do you like about these male clinics that advertise ED medicines? Should these patients see a urologist as well? I like this question only because early on when Viagra came out, there was a thoracic surgeon who was advertising for treating erectile dysfunction. Now,
what a great way to bring in potential thoracic cardiac surgery, open heart surgery patients. I mean, it's great, smart.
Yeah. So I think that, that as you said, it's a money maker, and so sometimes, and it's an easy, probably fairly easy thing to as treatment goes.
What do I like about the male clinics that advertise ED medicines? It brings this condition out of the closet into the forefront. It's normal to talk about sexual function for not just men, but also women. I want orgasmic equality. I want orgasmic equality. And there's so much, that's another topic we can talk about.
Female sexual dysfunction. Yeah.
Yeah. Female sexual dysfunction. Yeah.
All right. There's part 4 now.
Yeah. And
now everybody knows why this is a weekly show.
Yeah. I like to tell my male patients, because they're coming in for their ED, or they have something going on with their health and they're complaining about erectile dysfunction. They're here with their partner. I remind them that in about 70% of the time, the penis is not needed for a female orgasm. Right? So for a lot of my enlightened male partners, they say, oh yeah, we figured that out a long time ago. But for a lot of people, that is not common sense. They don't know that.
Yeah.
So anyway, that's a totally different talk.
It's a definitely good part 4. I'm gonna put it down on my list. Rachel Smith says, every prescription I write, I will print off a good RX coupon for the patient. I think it's a great idea. Single Care is another discount provider. Was that the one that you mentioned, John?
No, Cost Plus, Smart Cubans.
Right. Yeah. And I like this question. Paula Wagner put in, what do you do for penile rehab? I'm sure she's talking about post-radical prostatectomy patients. And that's a real important thing, is to get them sooner than later to start doing things to, if it's a vacuum device to keep blood flow going to the penis, putting them on a dosage of the PDE5 inhibitors, anything along that line, I think is a definite must. There's a guy that works out of Chicago by the name of Jeff Albo. He's RN that's specializes in this area, especially he's written a couple books now on post-prostatectomy rehabilitation, and I'm going to try to get him on to do a talk. There's number 5. So I think we've got a lot of food for thought here. Neil Smith, our younger ED patients are worked up, but often started on anti-anxiety meds first, usually with success. That's an interesting thought. Anybody else using that? Seen it?
I think
Lori?
that, our urologists probably want to deter that back to the PCP. They don't want to deal with anti-anxiety drugs.
And Rachel Smith says, I've been seeing younger patients as well. Agree it might be psychological. Will sometimes give low doses of Viagra, but stress, healthy lifestyle, adequate rest, etc. Rachel, I really like that comment. You know, we sometimes forget the holistic approach because there's more than one factor sometimes going on here. Monica Friedman, how strong is the correlation of ED in young men and use of weed? I would
not quite clear. I think they've looked into it. Lower to moderate dose of cannabis, it does not appear to be affecting erections, but higher doses may, but it's not well studied.
Yeah. Paula Wagner, as part of your workup, do you do penile duplex ultrasound for ED? And we don't. We did in the years past, did a whole bunch of tests. We used to put these bands around the penis to check for nocturnal tumescence, you know, the erections at night. And we found that you could put postage stamps around, back when they were cheap enough, around the penis for the same effect. And the results were nothing ever did any good. We never got any great knowledge out of those things. And the treatments were better than the tests, and they were expensive. So we don't.
I think before you order any tests, you need to ask yourself, is this going to change how I treat this patient? And if the answer is no, then don't order the test.
Yeah. And I think back to, again, you can make some good money off of it, because I can remember sales reps coming in saying, hey, do all these tests. You can, do a $2,000-$3,000 workup on this patient. Yeah, but I'm still going to do the same thing, the same treatment. That's important.
Here's part 6 of this talk for you, Vic. Claire asks, any thoughts on premature ejaculation treatments?
Definitely a number 6.
That's a huge talk.
Yeah.
And I'd probably add the same one would be anorgasmic issues, unable to ejaculate. We're seeing that come up more and more, especially in our elderly crowd. So, yep. And I think this will be our last question. We're running out of time. Great questions, by the way, attendees. Hopefully it was a good topic to get a lot of questions from, but you guys have been great. So Monica Friedman puts down, is pelvic floor therapy used or helpful? I don't think we've ever done it for erectile dysfunction.
Yeah, I'm not sure of its role in ED.
Lori, any comments on that? No.
I feel the same way you guys do.
I know it's really good, helpful for incontinence, but I haven't seen it in the ED realm. So, well, it's been a great discussion. I really appreciate all the input from our panelists. As always, you guys are great. Couldn't do this without you. Next week, here's a quick tease. We're trying an experiment. Originally, I had canceled out the meeting because I'm going to be in New Orleans as one of the speakers for the big SUNA meeting. But I decided, why stop the ball from rolling? Keep the momentum going. So I'm going to try a remote. So we'll see how this works. I've got the system set up to work remotely, and we're going to do a live from the SUNA meeting at 9 o'clock Central Daylight Time, and New Orleans is on Central Daylight Time too. But I'm going to try to capture some of the meeting ahead of time and show you what's going on. And I can't broadcast any of the talks because they're being live streamed by SUNA, but at least give you a feel for what's going on in the meeting. We'll do general questions. We're not going to have an actual deep dive subject, but tune in if you want to. If you're not going to the meeting, and if you are, hey, stop by and see me, say hi. Yeah, let's give it a try. We're going to see. Lori said she'll be there.
I told Vic he has to wear beads. So
No, I want to know what he does to get the beads.
Yeah, that's right.
we will find out next week. Stay tuned.
Hey, Vic, great job on the presentation today. And thank you all for attending. Remember, those who are watching, to invite your friends who work in the urologic arena to join us every Saturday.
Yeah, absolutely. And
It
for
is
those of you
free.
that didn't get enough, there is the after party. Go to euronurse.com, hit that big red button. The after party will be starting as soon as this one closes. So have a great day. It looks like the sun finally came out by me. I'm seeing the sun on my backdrop. So anyway, enjoy what's left.
Great job, Vic.
October
Keep up the good work.
coming up.
And I look forward to seeing you from Suna.
All right, great.
Thanks,
We'll see
Vic.
ya.